Okay, good afternoon, and Tuesday. We're getting to see some of the data coming in different ways. So we're going to talk about that when you see how some comes in early and some in late as it gets reported on there. So as I said yesterday, when we had our number down to 309, I said it's only a number for that day. We have to balance that with how lab tests flow and reporting issues there, and I'll comment on that after we get the daily updates and the numbers from Dr. Yaffe. So first, let's go over to Dr. Yaffe for the daily numbers.
Okay, thanks. As of 4 p.m. yesterday, the data in the Integrated Public Health Information System for Ontario, we have a total of 4,726 confirmed cases of COVID-19. This represents an increase of 379 confirmed cases from the previous report. Of those, about 35% are 60 years of age and older, and 52% are people who live in the Greater Toronto Area. 19% had traveled within the 14 days prior to becoming ill. Almost 15% had close contact with a confirmed case, and 19% had community exposure. 47% had exposure information missing or pending. Currently, the total number of confirmed cases that have passed away, unfortunately, is 153. And we're aware of at least 51 outbreaks in long-term care facilities. We continue to see the number of resolved cases increase. We're now at 1,802, which represents 38% of our cases. In terms of hospitalization, 614 people are currently hospitalized with COVID-19. Of those, 233 are in ICU, and of the 233, 187 are on a ventilator. In terms of our cases, we know that just over 500 are in healthcare workers, many of whom had traveled or had exposure through other means. The laboratory testing, we have now tested a total of 81,364 people in Ontario. 691 are currently under investigation. In the last 24 hours, over 4,000 tests have been processed. And this represents tests performed, not just people tested. Thank you.
Okay, so yesterday we reported in our Integrated Public Health Information System, which is our source for the data daily, 309, and people said, okay, the numbers are coming down, and we're optimistic on that. At the same time, I knew from the laboratory testing that number was up in the upper 300s, which made me aware that the lab tests come in, then they go to the public health units who correctly put in the data to the Integrated Public Health Information System, so it's the delay. So I wasn't surprised that the number today is the IFAS one is up. The good news is that the laboratory testing positive tests are down. And actually the numbers are below 300 a bit, so that you'll see that reflected tomorrow. Added to that, of course, is the ongoing issue we're talking about with laboratory testing. And we continue to work at that to understand the aspect that we can do easily 10,000 tests. What we're finding that through a lot of our assessment centers, the numbers coming in are diminishing, including the numbers calling telehealth and through our self-assessment tool. That can be a good news story, that because there's less people who either have had a concern about contact or travel history, which the travel history should be abating as that period is ending over the next few days of when the maximum amount of travelers, there still are a few, by the way, coming in, but we're monitoring those through the Quarantine Act, of course, at the federal level. But at the same time, those are dropping off, and people with signs and symptoms of significance seem to be less apparent. So we've been asked by many, can we do more testing? And of course, the testing is voluntary. We'd have to see how many people we can undertake to do other testing. We're looking at our priority areas and considering how we can even do more there, including our long-term care facilities, our priority ones with healthcare workers, aspects related to any outbreaks, especially in institutions, dealing with Indigenous First Nation communities, and adding that to there so we make sure we can get those done on a priority basis. I've noticed that in the assessment centers where there's been some comments about a week or 2 weeks ago, they were being very careful on prioritization of testing because of the concern of the lab capacity at that time as we were ramping up our capacity. But lately I've noticed where in the past they were testing 60% of the people came, that number has moved up to somewhere close to 80%. So they seem to be doing that much more openly. And I've heard from some different centers that people with symptoms and a history of significance, or they think they've been in contact, are being tested. So we're seeking to have those individuals who have a history of symptoms compatible with COVID-19, especially if they've had a travel history and a contact with a case or a suspected case, or they may be unsure they might have been in a setting that they got in contact, that they would feel at ease to go to the nearly 100 assessment centers around. Contact your family primary care doctor for advice, or still use telehealth. Even the numbers are down there, and also they can still use a self-assessment tool, but there's nothing that inhibits you from going and getting tested if you have those concerns and, of course, symptoms compatible with that. So that's one aspect I wanted to clarify there in that regard, and to note that the other aspects is that as our other parts of the country seem to be seeing similar effects, even Quebec, as the Premier of Quebec was noting some optimism around some potential flattening and seeing that impact there. So we're trying to monitor those, as all of us are, and with some optimism that we may be on a pan-Canadian basis potentially bending the curve. But of course, we have not heard the modeling numbers from the federal level yet, because they're doing the whole collation of the national data in that perspective, and we're waiting to see when that report would come forward and how are we tracking as a nation as compared to each province and territory, because the risk with each province and territory is we vary so much in size, sometimes 3 to 4-fold different population numbers. That makes comparisons challenging and difficult in that. So with those comments, I'm going to open up for questions from the...
Okay, we'll take the first caller's question.
Your first question comes from Laura Stone with the Globe and Mail. Please go ahead.
Hi there, doctors. I'm wondering about the policy for testing at long-term care facilities. I'm hearing from some local doctors and facility administrators who are concerned that they aren't able to swab and test incoming residents, even if they are asymptomatic. Will you be changing your policy to ensure that all residents of long-term care are tested for COVID-19, regardless of symptoms?
I mean, we're always reviewing our policy and based on the best evidence and the experiences. Our current policy is that people being admitted from hospital to a long-term care facility, first of all, have to be in stable condition. They have to be have no symptoms of COVID-19 and have no fever. They are not routinely tested. They are admitted and put into a self-quarantine for 14 days and very carefully monitored, at least twice a day for symptoms, including temperature. And that is how we're dealing with it. However, we have increased testing if there's any inkling of symptoms in a resident or staff person in a long-term care facility. They are being tested for COVID-19, and if it's positive, we make sure, or we are recommending strongly, that anyone with symptoms in the facility, be it residents or staff, be tested for COVID-19.
Follow up?
I'm just wondering, what I hear you on all of that, but what would be the harm of testing everyone coming in? Is it an issue of shortage of tests? Do you feel like it's a waste of time? If you're hearing concerns from people who say just anyone who's being admitted to the home needs to get a test, what is the issue with that?
Well, we have had no evidence of people coming from hospital into a home bringing COVID-19 in. And certainly we are monitoring. If the person is coming from a hospital with an outbreak, they wouldn't be coming into the home until things have been sorted out for sure.
Next question.
Your next question comes from Victoria Gibson with iPolitics. Please go ahead.
Hi, doctors. Prior to the virus hitting in Ontario, were you aware of any simulations or reports that may have laid out how prepared the province might be for a pandemic? And were there any warning signs brought to your attention before this hit that healthcare facilities might struggle accessing things like protective equipment or ventilators or testing materials?
So the pandemic plans that have been in place since SARS and following that, we have been working on at a federal, provincial, territorial level at the province through our medical emergency operations center. We have undertaken to put those out and make sure people are aware. A number of them, and I know when I was at the local level, we have done tabletop exercises giving a simulation of saying if we did have this and with different factors, and they always throw in some other things like large other issues of motor vehicle accidents that really test your system. Can you cope? How will you handle this? And you bring your local people together to do some planning, whether it's first responders, hospitals, long-term care facilities. In the past, under some of the local planning groups, such as the LINS, and now under OH, would be in that similar situation. So we've done that. We've done some provincial ones, larger one. They take a lot of planning to put in place, and everybody participates and makes sure your contact information. So these have been done and have been carried out because they help to identify what changes have taken place, what you may not be aware of, and how you plan that. As far as the question on knowing about shortage of supplies and materials, in that sense, we have and continue to purchase. We had stockpiles before of some aspects there. Mostly with influenza, we had antiviral stockpiles, and we continue to look at buying and replenishing those. So there are some stockpiles. We had some ventilators already in our stockpile in that, and they have some maintenance and renewals. And of course, a number of them do expire, and we have replacements. So did we anticipate the level of severity of shortage in there? As this is our first real, true global pandemic, our other ones have been very, very much localized. So even when we had the H1N1 and the impact on some of our hospitals, we had no difficulty of obtaining supplies because other parts of the country and other parts of the world were not equally impacted by that. And so we could always get our supplies and materials. So for many countries, this is a first. And seeing that in place, many are trying to address that issue of how would one ensure supply in the midst of a global shortage, in the midst of a global pandemic. I mean, this is our first. And a lot of lessons learned and understand that, as you've heard from the Premier, seeking to ramp up our ability, even Ontario, to do our own production in that. And I think a number of other settings are wrestling with that and trying to address that as best they can. Those that have the capacity, the manufacturing, and the scientific expertise to do so, such as Ontario, are looking at that wholeheartedly right now, and with strong direction from the government and from the Premier in that regard.
Follow up?
Thank you. And just to follow up on what you were saying about the province-wide tabletop exercises or simulations that you've done, when was the most recent one on sort of a larger provincial scale?
We did some on the basis of, at the time, on the Ebola crisis, and we looked at some aspects there, how we would respond in that light, because at that time we were addressing like certain centered hospitals, transferring patients and movement and that. So remember, that was one of our most recent ones, and we were concerned about the impact of the Ebola crisis and how it might come to Canada and impact us in Ontario.
Next question.
Your next question comes from Morgan Campbell with Global News. Please go ahead.
Thank you, doctors. Can you tell us how many transfers of patients from hospitals to long-term care facilities were approved? And when you say there was no evidence that any patients carried COVID-19, what evidence do you have for that? And how do you know this if some of the patients or many of the patients were not tested?
Well, Dr. Yaffe can add some few comments there. In our outbreaks, if they found that one of the cases, in fact, had a history of recent transfer within, say, 48, 72 hours or even and longer, that would have been noted. What we've heard so far is a lot of the clients and unfortunately some of the ones who have passed away have been more longer-term residents of the facilities in there. Of course, we're watching for that. I know the homes are watching for that, and always at the hospital centers there where we started with stringent criteria for any patient coming in from outside with suspected respiratory, really enhance the screening as well as the monitoring and proper PPE. So hospitals have been on high alert since January to ensure that those patients and clients identified and go through the proper isolation facilities, even into ICU and isolation, et cetera, have been closely adhered to. So therefore, we would, as Dr. Yaffe said, we would not transfer patients from a hospital that was experiencing an outbreak. Hospitals do have cases, of course, that's what they're there for, and they're in proper isolation facilities and handled accordingly. But they would never transfer general ward patients in the midst of an outbreak in their institution, and long-term care facilities wouldn't receive them. So from a number of standpoints, you'd have to ask, okay, why would the hospital inadvertently do that if the person's been in, because these are often ALCs, they've been sometimes in the facility for a long period of time and didn't demonstrate any symptoms of it, and then they're transferred, and then at the same time, if we were getting history of that from the outbreaks that we're seeing in long-term care facilities, we've not been alerted that a number of the cases identified were recent transfers, and I mean recent like in the last week to 10 days in that, but we'll be advised by that if it does occur, and that would be part of the ongoing investigation. If it was a recent transfer and the person's positive, you have to ask where they came from, and you go back to that facility and saying, what do you have actually cases in your facility you weren't aware of that you did that transfer? So that's all part of the outbreak protocol and management.
Follow up?
So, do you know if any long term care homes developed outbreaks after hospital transfers, and what have you been doing to monitor this?
Dr. Yaffe.
Yes, we're not aware of any. Now, of course, outbreaks are reportable to the local health unit, and the local health unit does the investigation in terms of where the infection might have started. Where did it come from? Was it a visitor? Was it somebody? Was it a recent transfer? And at this point, there have been no outbreaks that have begun from somebody who's been recently transferred from from a hospital.
Next question.
Your next question comes from Catherine Burlott with Radio Canada. Please go ahead.
Hi, doctors. My first question is about the famous curve. So we've talked about the last couple of days, the last week, the couple of weeks, flattening the curve for sure. But we've also heard a lot about reaching a peak. Can you just explain if there are any specific criteria that would let us know we have either reached that peak or passed that peak, and what you need to make that assessment?
Well, I was talking about some of that data yesterday, and our epidemiologists and also data we supply to our modelers, they put those daily amounts of cases, daily amounts of hospitalization, ICU admissions, as well as deaths on the various curves, and look at those trends and directions to see, are they continually on the rise? Because these are basically statistical data and information, and mapping that. The sensitive one, of course, that we're asking about is the case counts. And as I said earlier, last week, at the end of last week, we peaked at about 462 in one day. Before that, we had been below around 260, and then we went up to there, and then we sort of came down slowly in the in the low fours and the upper threes, and now we've had just a couple here, and we may go down a bit lower again. What we want to know from our statisticians and from epidemiologists, does this look like a sustained trend and direction, much like you hear from BC, where there's an indication it's flattening down, but you want to see that sustained over a period of time, and rather that maybe it's a temporary blip due to some other reasons you didn't notice. And that's why a number of them are asking, maybe we need to do even wider testing to people who have less symptoms or have no history, and how would we do that in the case where we'd have to sample, and we're doing that with our sentinel testing of other people in facilities, and we so far have not found many related to that at all, just a few, and one was related to one of the outbreaks in a nursing facility. And so we continue to ask that question to our surveillance team as well as our lab testing, saying if we're going to expand, if the number of people coming forward voluntarily is decreasing, in a way that tells a good story, but how do we make sure that we're not missing anything, and can we do a wider breadth of testing, and not just doing it for the sake of doing it, but that would give a better sense for the modelers to say, do we have a comprehensive picture, yes or no? And so they're wrestling with that question live time right now that we have a capacity, especially in this last week, to go beyond that, knowing that we have a lot of pressure to do even more specific outbreak managing testing, as in long-term care homes, and concerns with other priority groups such as prisons and homeless and Indigenous First Nation communities. So these are all priority areas that we do not want to miss on or delay.
Follow up?
Thank you. So the City of Toronto just released that they have to recall poor quality surgical masks that were distributed to staff. I'm wondering if you are aware of any such equipment that was distributed elsewhere in the province, and if you can comment as to equipment that is distributed is actually high quality.
Well, that's one of the aspects of our whole group that's looking at personal protective equipment, especially related to the healthcare workers, the use of the N95s and the surgical masks, because they meet certain criteria set out by experts and standards, both some in the States and some with Health Canada. And when you get sometimes donated equipment, one assumes, one, it isn't expired, and second, it meets all those qualifications, that it hasn't been exposed in a period of time to unusual environmental conditions that may have caused some deterioration. I'm not sure what the aspect was related to the Toronto ones, but I think one wants to be diligent in assessing the status and the quality of that, much like you do with products. Is it expired, not expired? Does it have the proper certification and codes on it, etc.? Because we get these days a lot of different people donating and giving things that are supposedly of quality, and we thank them for that. And doing that at the same time, there's a wide variety of other ones out there that we want to make sure we've assessed, especially for our healthcare workers, that they are not only are the quality product, they're not expired, and they will ensure the safety of our healthcare workers. So it's good if Toronto did pick that up, and we'll have to investigate to see how that got out into the field and was. And what was the reason why it was no longer of proper status and quality.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hello, doctors. I'm wondering, this is flicking back to Christine Elliott, what she was saying at the Premier's news conference on increasing the healthcare workforce. What kind of work might an international medical graduate be able to do if he or she is not licensed in Ontario and doesn't manage to get through any expedited licensing process? Where might they be deployed?
Well, I think there's a lot of areas where people with medical knowledge, medical students, international medical graduates, other people from other sectors that have a knowledge of medical one can, I know especially in the public health sector, they have and are assisting us in our need to rapidly expand our case contact management, because you have to have individuals who have enough medical knowledge to answer questions from the public to determine which questions may necessitate a further call from one of the licensed individuals or referral on. So when you call in, you would like to have someone who is not only conversant, but also has enough knowledge base that they can deal with your questions and answers and ensure that if there's anything of any significance, it's not missed and taken up. So we could certainly utilize large numbers in that regard, where the actual license, the so-called scope of practice type aspect, is not being exercised by that person in that regard, and therefore it doesn't violate any standards of colleges of regulation groups in the province in there, because we still want to maintain those standards as best as possible. I'm not sure, Dr. Yaffe, if you have any further comments on the various utilization. I know a number of other hospitals can use them in various positions where they're not carrying out designated acts that do require certification and scope of practice, much like there's certain things that degree nurses can do and others that can't do other things, and it's all part of laid out through their various regulatory colleges and official documents.
Follow up?
Yeah, on testing, I think the minister said you're up to a point where you can do 14,000 tests a day, but it sounds like we're way below that. So isn't that a wasted gap?
Yes, the capacity has grown significantly, which is great. And so now, as Dr. Williams mentioned, we need to get more people tested. So the assessment centers are testing more and more of the people that are showing up, but we're encouraging them if the people who show up have symptoms and there's some concern, the capacity issue isn't what it was. They should be testing. We're also looking at more testing in facilities where there's an outbreak, more testing of healthcare workers as appropriate, Indigenous communities, and so on. And there's a group, an expert group, that's going to be reporting very shortly, looking at testing strategy. Because obviously we have a lot of capacity that we want people to be tested, but we don't want to go overboard and end up with another backlog. So it's a fine balance, but we're definitely looking at more capacity, and I think it will grow a bit more as well. It's expected to go to around 18 or 19,000 a day.
Next question.
Your next question comes from Allison Martell with Reuters. Please go ahead.
Thank you. What proportion of cases are Ontario's public health units able to trace contacts for right now? I think yesterday you said something about 48% having unknown exposure. Does that mean that no investigation has been done on this?
I heard the question about 48% have no non-exposure. I didn't quite get the whole question.
What proportion of cases are receiving contact tracing right now?
Okay. Well, all the cases do get some contact tracing, but ideally, what we would like is for particularly close contacts to be called daily for 14 days. That is the ideal. And I don't know what percentage are actually getting that. So that's why we are working with Public Health Ontario to get volunteers from Health Canada and medical students to support the health units in doing more contact follow-up. But they're all getting some follow-up.
Follow up?
Do you have numbers on probable cases given how narrow testing has been lately? Seems like a less and less representative number of confirmed cases.
At the moment, we were doing some probable cases when we thought our capacity was going to be down, and we were saying that some that because of limitations of laboratory testing, we were entertained to have some that could be connected to a case that had signs and symptoms, and that was a probable. Some health units were collecting those for a short period of time. Now, with the ability to do even more testing, we would say, well, instead of calling it probable, you can go ahead and test that person anyways and do that. So that's one of the benefits of having the lab testing picking up. Some other provinces have had to go to a probable one because they're also facing some limitations on testing as well. This was a pan-Canadian problem, and we're all working hard to pick up our capacity across the country. So the role of probables in there is one that the definition has been changing and moving as we deal with our capacity and ability to do the total overall comprehensive testing.
Okay, we're going to move on, and this will be our last question.
Your final question comes from Haley Cooper with News Talk 1010. Please go ahead.
Hi, Dr. Williams. Hi, Dr. Yaffe. I wanted to talk about the number of test results that are being announced. They've started to significantly decline. They were at 6,200 results on April 1st. Today was just over 2,500 results that were announced. So doesn't this decline skew the numbers, and why are those numbers going down rather than up?
Well, that's a good question. And as I said, I'd like to be optimistic in saying the numbers are going down because there's, one, less people who have traveled. less people who had contact with a case that they know of, and maybe less people with any signs or symptoms. So we have been encouraging people with any of those, and if they don't know the exact contact and any compatible, to go forward and get assessed. So we're not trying to limit that, and they can do that through various channels, as I said already in that notification. So the good message could be that we're, because that the people coming forward is ahead of the testing, which is ahead of the hospital admissions, et cetera. So it may be some evidence of some flattening. We've had some decrease in our load for telehealth. We've had decrease in the self-assessment tool accessing. We've had in our syndromic surveillance tool that we use for all the emergency departments, we've had some continual decreasing in respiratory conditions related to ILI or influenza-like illness. So it overall is a trending in a good direction. Then the lab testing there, while there's the number you quoted, there were individuals, they did a whole bunch of other tests because in that some of those individuals, especially now we have a number of them that had been admitted into the hospital, they will do a number of other tests on those individuals, including sometimes 2 to 3 samples on some. So those are called tests that are done. They don't count as individuals because it's the same person. So it means that the lab testing is still being done regardless in that manner. So I guess if you go out and do a lot of testing, you talk about bias. I mean, what could go out and do a whole bunch of testing people you know are probably not going to be there, and you can put up your numbers and show you have a real large negative rate. That would be a biased type approach, and that's what we have to ask our experts to say, if we want to do a sampling maybe, how would we go about that so it was not biased and was a really reflection of the population at large? So these are questions we're asking too. Should we undertake to do that at the moment while we do have some capacity in that regard to go around, and if you may, open up and I wouldn't say beat the bushes, but try and find some that are out there. But at the same time, as Dr. Yaffe said, sometimes these things ebb and flow, and you could get into another surge again. And if you compromise yourself, so you used up your reagent and your swabs, and your supply, someone would ask at that time of the crucial need again, why are you not more vigilant and cautious in your use of those supplies? Because now, when you need them, you don't have them again. So we want to make sure that we're not concluding that there's no need at all. These things have had a sense of ebb and flowing, and we've always put that out as a precautionary level, much like we experienced with SARS, where we were convinced it was over, and then we had a fairly large rebound afterwards. So we want to do something where we could utilize that, but these supplies and issues around the different chemicals that are used for these tests, as well as the swab kits, they're also on global demand, and one wants to be a good steward of those and make sure you need it when you need it for the ones that are critically necessary. So there's a balancing act, as Dr. Yaffe said, and you have to put that in perspective.
Okay, we'll do a follow-up, and this is the last question.
And Dr. Williams, you said something that caught my attention. You said that testing is voluntary. So do we have a number of how many people, if any, have had symptoms significant enough that a test was recommended, but that test was declined by a patient? And would that be considered a probable case, or is that patient, that number, completely ignored?
It wouldn't be ignored. I would have to guess how that came to our attention. They might have done a self-assessment tool and decided not to, or just to take the advice and self-isolate. We've had, I'm sure, a number of them who did that. We asked them to contact the public health unit in that case to say that they have assessed themselves as being potentially a case, and the health unit then might say, well, we're going to label you as a possible or potential case. We used to call them person under investigation, and we would follow them along because we asked them to do the 14-day isolation, and we would monitor them during that period. So we considered them to be case equivalents at that time because we didn't have the laboratory testing capacity to do everybody. More recently, it's been opened up, and everyone that I'm aware of, the centers are being much more open about that testing. I think if you had someone who said, I have a travel history or a case, I have signs and symptoms, but I don't want to be tested, and they talk to the public health department, then the public health department would probably say, like the original ones, well, we would encourage you to get tested, but Meanwhile, we would like to maintain contact with you. We'd like you to isolate. We'd like you to follow all those due steps because it sounds like, and you seem to fit the case definition, and thank you for being forthright and coming and talking to us. And we will make sure that you get the support you need during this time. And if there's some exacerbation or increase in your symptoms, we'd be encouraging you to go to an assessment center, or if it was quite a sudden increase in your shortness of breath and that, to call 911 or go to an emergency department, because that could happen during that time. So we would really like them to still come forward and see us, and we would really like to be able there to support them during their 14-day period to ensure that it was a normal course of recovery. And it helps us to know that data as well, even if they had some reasons for not wanting to get tested.
Thank you. That's all we have time for today.